Hi, my name is Justine Casola, and I am a second-year medical student at Kentucky College of Osteopathic Medicine. I'm going to be presenting today on a case of bilateral diaphragm paralysis due to somatic dysfunction, and this presentation could not be possible without my mentors, Dr. Antoinette Justice and Dr. Aisha Gayer. So we're just going to be talking about diaphragm paralysis, the patient presentation, past medical findings, exam findings, follow-up, and a discussion. So diaphragm paralysis could present unilaterally or bilaterally, impairing the contraction of the diaphragm, and this really inhibits your ability to take a deep breath in. Some causes of diaphragm paralysis include phrenic nerve injury, amyotrophic lateral sclerosis, and post-polio syndrome. However, 20% of all cases of diaphragm paralysis are idiopathic. Symptoms include dyspnea, orthopnea, and reduced breath sounds bilaterally, and treatment just includes mechanical ventilation, oxygen therapy, CPAP, and pulmonary rehab. Today we're going to be discussing how OMT addresses the somatic dysfunctions, which may result in reduced pain. It may facilitate movement and enhance lymphatics and neurovascular flow with patients with diaphragm paralysis. So the patient is a 59-year-old male who in 2009 was just walking around his house where he became suddenly very short of breath. He went to the ER and he was negative for a PE, chest infection, TIA, left ventricular systolic dysfunction, but his EMG studies did show a phrenic nerve injury and neuropathy, and the patient was only stating at 70%. He was diagnosed with bilateral diaphragm paralysis and was treated with continuous nasal cannula, BiPAP, and pulmonary rehab. The patient does have significant past medical history and past surgical history, and is disabled and a former smoker who quit 20 years ago and is an infrequent social drinker and does not have any known drug allergies. So the patient in 2012 presented to the Pikeville OMT clinic where he was on BiPAP 3 times a day for 1 to 4 hours and continuous at night. Pulmonary rehab did help him over the last 4 years, but he could not lie flat for more than a few minutes, and he became increased shortness of breath with minimal exertion. So prior to OMT, he did have low back pain, some muscle tightness. He could not take a good deep breath, and he had no range of motion and was only statting 84% with BiPAP and 2 liters of oxygen and could not tolerate walking. So an osteopathic structural exam was performed and the area of greatest restriction was treated. The treatment methods used were muscle energy, functional technique, balanced ligamentous tension, and traction tug. After the first session, his low back pain pretty much stayed the same, but his muscle tightness improved. He could take a deep breath. His range of motion improved, but the most significant finding that a 2-minute walk without oxygen, he maintained 92 to 97% saturation. He even quoted, "I feel like I could go out for a run," and there was more air movement in the lower lobes on auscultation. The patient did return for a second OMT session, and this time a pre-OMT spirometry was recorded, and again, the area of greatest restrictions were treated, and they were using the same technique as last time. Results after the second session included his FVC increased by 240 cc's and his FEV1 increased by 240 cc's. Off of oxygen, he maintained a 93% SpO2 at rest, and the patient was less fatigued, more active, and there was better air movement than after the first visit. Present day, the patient goes for regular OMT to treat somatic dysfunctions. He is stable and off oxygen. His phrenic motor studies still are absent bilaterally, and the diaphragm paralysis remains in remission. So OMT is used in treatments of other lung diseases such as pneumonia, pulmonary fibrosis, and cystic fibrosis. The techniques used in this case study, such as muscle energy, counterstrain, functional technique, helped stretch and mobilize the diaphragm. And we know that the diaphragm is connected to the bottom 6 ribs and the lower lumbar spine. So if you could use these techniques to help stretch it, it could help these patients actually take better deep breaths and facilitate more air movement. OMT may have helped decompress the phrenic nerve, and regular OMT treatments can help improve oxygen saturation and reduce home oxygen dependence to improve the patient's lifestyle, especially patients with idiopathic bilateral diaphragm paralysis.